afternoon, everyone. Thank you all for coming. I know this is the post-lunchtime slot, so I really appreciate you all smiling still, looking very alive. So I'm pleased to see you all. I am Imogen Stringer. I am a critical care nurse by background, currently a senior nurse educator at Imperial College. I've recently just finished a Chief Sustainability Officer clinical fellowship as well, where I was working within the Greener NHS team and the Chief Nursing Office, where I was going to be joined today by Val, who's the National IPC lead within the CNO team. But unfortunately, she's not well enough to be presenting with me today. So unfortunately, you've just got my voice for the next 40 minutes or so. So I'm going to be talking to you today about sustainability and infection prevention control and the links between it and some of the work that we've been doing around slightly more of a collaboration. So if you are happy to and have the ability to have a device that's free, I would love it if you could scan onto Menti just to answer the first two questions, just to gain a bit of an understanding as to what sustainability means to you and what that means in your current roles that you have. So hopefully that should bring up the first question about what does sustainability mean to you. And I'll leave you to go through the first two questions, and then right at the end of the presentation, we'll move on to the final questions. So, what is sustainability? So the dictionary definition, sustainable is an adjective, being capable of being sustained, of relating to or being a method of harvesting or using a resource so that the resource is not depleted or permanently damaged. So if something is sustainable, it means we can keep doing it without causing harm to our future indefinitely and without running out of resources. So this I always find is a nice way to sort of ease into presentations with this infographic. This chart on the screen here shows that in 1971 it starts from, it shows us how many Earths we would need to sustain the resources that we currently use. So you can see in 1971, 1973, we needed one Earth. We had the Earth that we have, and that was able to sustain our resources. You can see as this graph goes along to 2023, apologies, I haven't got it up to 2024 yet, but we're currently using 1.7 Earths worth of resources to sustain the lifestyles that we are currently living today. So even in quite a short period of time, you'll agree, just in the last 50 years, we are time and time again using more and more resources without sustaining them. So we'll eventually be running out of resources. And if we look at that in the terms of how each country might live their lifestyles and use the resources, you can see there's quite a wide variation that each country lives. So it says that if Earth overshoot was to live, if everybody in the population was to live, say, as Qatar does, we would run out of our resources. If we started the year in January, we would have run out of our resources by February. But in comparison, Jamaica, we would make it through to 12 months. So you can really see, you can identify that the UK sort of sits around the April, May, June time. No, actually, yeah, it's May time. So the UK is May. You can see that different countries are using different resources at different levels. But as a global consensus of our resources, we are still using over the amount that we're entitled to. We're using 1.7 Earths, and we don't have another 0.7 Earths to have. So what does that mean? So CO2, I'm imagining, is something that we quite commonly associate when we're talking about sustainability. So CO2 is the byproduct that's emitted when we burn wood, oil, coal, or gas. And everything on this Earth has a carbon footprint. It's absorbed by the planet, but we do emit currently more than the planet is able to absorb. So currently it was 280 parts per million prior to the Industrial Revolution. And when I was born, that then increased to 330 parts per million. So that's a 21% increase of carbon dioxide just in 200 years. And from 2023, that's risen to 424 parts per million. So we've got another increase there of another 28% in just a few years. So 50% of the CO2 ever emitted by humans has been emitted since 1990. So really, in a really short period of time, we've really upped the amount of CO2 that we're emitting. And moreover, the more heat that's trapped, the planet gets warmer. And I think these next graphs really do demonstrate kind of the severity of the carbon dioxide and the current things that we're experiencing now. We're not looking at projections anymore. We're not assuming that this might happen if we continue the way we do. We are seeing the effects of climate change and the increase of CO2 in our current lives. So you can see the sort of this graph trend. We've never been above that sort of dotted line before 1950, and you can see that really sharp peak as to where we are today of our CO2 levels. And in the last 12,000 years, this is an increase of our temperatures. So that CO2 increase and what that relates to the temperatures we then feel on Earth. So currently, since the pre-industrial times, we're now at a temperature of 1.45 degrees. So we can see by that red right at the right-hand side of the graph, we're really going into sort of unknown territories with how much of an increase of our temperature we're seeing. So the global temperature variations, again, this is a very similar graph. It's showing that we've always kind of sat below this line with the invention of the steam engine as a nice marker of time, and where we are now. So you can see we're much higher than we've ever been before. And I'm sure you will have felt that in our last few years or so with the heat that we've been experiencing, even just in the UK. And this graph with the different blocks of colour shows the differences of the sort of daily average temperatures. And the darker colour shows when there's a record that's been broken. So you can see that from the 15th of August last year up until the 8th of December, every single day, so 116 days consecutively, we broke a record of heat temperatures for that year. So we're seeing it more and more. I think we can't really get away from the fact that climate change is presenting more and more problems that we are seeing on a daily basis in all of our communities and populations that we either serve or work in. But why does that matter? So a warmer planet means warmer seas and a warmer atmosphere, which it might sound, oh, great, I like a nice hot summer. I much prefer that to the cold. But that doesn't necessarily mean that that's what it's going to be. If we've got a warmer planet, we have more energy in the seas. And the more energy we have within our water, the more storms that we're going to be seeing, which I'm sure we've also been affected by in the recent storms that have been affected. Even just getting to work sometimes, the trains are disrupted every time we have a storm. So we're seeing it more and more. And our rising sea levels mean that our ice caps melt. So we also have the flooding risks, permanent and seasonal, in places that we might not have seen before. I don't know if you saw the recent events in Dubai, for example, where there was the most amount of rain they have ever seen. And that also, the flooding then, if it becomes permanent, we've also got our loss of land. So you can see we're building more and more of a picture of the consequences. And the impact of land loss means that we have then impact on our food supply, and we have the sort of shortages of resources with the food, which I'm sure we've all experienced when we've been trying to go to our local supermarkets, and sometimes there's items that we're not able to get at a time that we normally would. Which means that we get the competition of resources, and that can sometimes bring conflict that we might see too. We also then get an increase of migration of people moving to where the resources are. And we have our tipping points. It's not all come up in one slide. Oh, it's coming. Okay. So what does this mean for us in the healthcare sector? So the impact of climate and human health is... This slide shows a few, but I think this is a really nice infographic, but it certainly doesn't stop to what this slide shows. But you can see we've got our rising temperatures, which brings our more extreme weather, which brings our rising sea levels, all caused by our increasing of CO2. And this leads us with consequences such as air pollution, where we're seeing more respiratory and cardiovascular disease in our patient groups. We also get changes in vector ecology. So the impact of climate change is bringing increased cases of malaria, dengue, and encephalitis, Lyme disease, and a few others that are on this slide. We've also got the increasing allergens. So again, we're seeing more respiratory allergies and asthma. It also affects our water quality, so we're seeing higher cases of cholera, also in places that we wouldn't normally see it, and a few others. And we've got our water and food supply impacts, which obviously impacts on malnutrition and diarrhea disease. We've also got environmental degradation, so that's the forced migration, the civil conflict, and the mental health impacts which come with that. We've got our extreme heat, so a lot of heat-related illnesses and death, and also causing cardiovascular failure. And the severe weather also, with the events that we're having, we see increased injuries, fatalities, and also the lasting mental health impacts. So you can see that just, it seems like 1.45 degrees increase. What does that really mean? But I hope this slide really does capture what that means for our human health and why it is so related to each and every healthcare professional to take note of what's happening. NHS England has quoted that the climate emergency is a health emergency. Climate change threatens the foundations of good health with direct and immediate consequences for all of our patients, the public and the NHS. Without accelerated action, there will be increases of intensity in heat waves, more frequent storms and flooding, and increased spread of infectious diseases. So that's what the NHS England has reported. And the World Health Organization reports that the climate change is the single biggest threat to health threat facing humanity. So I don't think we can, this sort of diagram shows that people are getting the water out the boat, but they're sure glad the hole isn't at their end. But we're not really seeing this anymore. We can't avoid it. We're seeing it time and time again. I'm sure those of you that are patient-facing are seeing it more and more in your patient groups. But even outside of our hospital settings, in our personal lives, I'm sure we're seeing the consequences. So what are we doing about that? So the Greener NHS works within the NHS England, and they, in 2020, it was part of our mandate in the Health and Care Act that we need to start looking at our carbon footprint as a part of our sort of NHS system. So the climate emergency, as I've said, is a health emergency, and unupdated, it will disrupt care, it will affect patients, and it affects public at every stage of our lives. I think we all expected the NHS to continue to be what it was when we first made it, to continue to look after patients time and time again, so that everyone has access free at the point of care. But we're seeing more and more with the challenges that we're facing with climate change, it's not going to be able to sustain these increased populations and patient groups that are now going to be requiring increased care. So we're seeing more major diseases, our cardiac problems, asthma and cancer are more prevalent, as sort of the last slide, which shows some of the impacts demonstrated. The NHS itself is responsible for about 5% of our national carbon footprint. So that's more than aviation, more than the aviation industry, which contributes to about, I think it's about 2 or 3%. So we have, as an organisation, we are certainly part of the challenge, but we are also certainly part of the solution. If we act on climate change, the direct improvements for public health and health equity, reaching our country's ambitions, which is under the 2020's Paris Climate Agreement, we could see over 5,700 lives saved every year from improved air quality, and also 38,000 lives saved each year from a more physically active population, and also 100,000 lives saved from healthier diets. And I don't know if any of you are familiar with this pie chart of the NHS's emissions, but I think this is a really interesting breakdown as to what and where our priority areas to start decarbonising our NHS is. When I first sort of stepped into the sustainability space, I always thought it was about waste. I always thought it was waste recycling was going to be my top priority. But actually, you can see in here, waste is actually only 5% of our whole NHS carbon footprint. And a lot of it actually sits in our scope 3 emissions, which is those bits in the blue, which are things that we can influence, so which supply chain covers quite heavily, our medical equipment, our medicines and chemicals, alongside a few other things that I mentioned there. So the response. So you might be familiar with this document already, which is the NHS responses delivering a net zero document, which landed in 2020 following the Health and Climate Change Act. Health and Care Act, sorry, I'm getting too carried away with climate. And this report sets our ambitions which are getting closer and closer. So our net zero ambition within the NHS is for the emissions we control directly. By 2040 is the ambition to have a 80% reduction by 2028 to 2032, which is scarily close. And the second ambition is for net zero emissions that we can influence. So that's our sort of carbon footprint plus, which is our sort of scope 3 emissions, so things that we don't directly control. So estates would be part of something we control, whereas the influence might be our patient travel carbon footprint. And again, the ambition there is to reduce by 80% by 2036 and to 2039. So we have some more guidance and things to help follow, but we are now NHS is the first health system to embed the net zero legislation. We were the very first one, and many countries are now following suit. There was a real movement from COP28 last year when more and more countries have been signing up to be making ambitions or commitments to be reducing their carbon emissions within each country, Australia being a good example of one that's just released a plan. So within the UK, every NHS trust and ICB now has a net zero strategy, so hopefully you might be familiar with your own green plans. And this is also then led up with the CQC is now to have its regulation under the well-led, where sustainability is going to be a key part of that well-led structure. So you might have already seen it starting to, if you're based clinically with your ward accreditation programs, for example, you might see sustainability coming more and more into the things that we're auditing and looking at. So what's it got to do with infection prevention control? Many healthcare practices are driven by IPC guidelines and risks. Sometimes these risks are very real, and we can see the relation, but sometimes we're like monkeys in a cage. Sometimes we don't know whether there is actually a real risk or whether it's a perceived risk from IPC. I don't know if you're familiar with people saying, we can't do this because of IPC, or have you asked IPC, so we're not going to do it until we've got everybody on board from IPC. IPC have said no, end of, we don't move any further, whereas actually have we asked them in the first place? We need to start reevaluating this culture of passing the blame to somebody else. IPC seems an easy place to leave that, oh, we're thinking of doing something, but no, we can't do it, IPC say no. And we need to start moving away from that, because time and time again, if you actually look into that a little bit further, they've either not been asked or it's just that the communication hasn't got through, and they certainly would not say no. They're actually probably some of the most supportive teams you can get in some of the acute hospital settings I've worked in. IPC are the ones that have really helped me push some of the initiatives along. So I think this barrier needs to be reevaluated and ask what the actual real risk is. And I guess as part of all of our everyday practice is that we need to be putting the planet as part of our risk assessment. Because without looking after the planet, we aren't going to be able to provide any of the care that we currently do. Even with the greatest innovations and technologies that are coming to our daily practices, we won't be able to use them if we're not looking after our planet. And there's a little bit about yellow washing, which is a term that was coined, I think, by Dr. Mahood, who stated that the implied risk of infection is disproportionate to the infection control evidence or principles. So I guess that's the thing that we're trying to avoid and move away from, is that IPC is actually a real part of the movement and the change, and IPC can actually lead a lot of these sustainable changes. You're already doing so much already, but it's about making people aware of what they already do and contribute to, and they're not actually the ones that say no. IPC, from the slides from before, you can see that a lot of the impacts that we have from climate change and health, a lot of them are infection related. So we're seeing the sort of the respiratory, the sort of higher cases of diseases. So it's sustainability and IPC are interlinked, interwoven at every step of the way. And there's also a large building research of microplastics and how that's affecting our sort of health and well-being as populations and patients. But what can we do about that? So there is, if we look at, say, some of the resources that we use, we're looking at the sort of mining and extraction to be able to create a product, get the component, the raw material that we make from the manufacturer. Then we produce that product through the manufacturing process. It goes to our service provider. We then use it. It then goes into waste. But what we actually want to be doing is try to reduce some of these products. Reuse everything we can and recycle whatever we can't reuse. So it isn't actually just about we need to do more recycling. It's about further up the chain than that. We want to be reducing our consumption in the first place and then try to reuse the things that we have and then recycling, which sometimes can be a quite common misconception, and refine anything we can't recycle so we can then minimize its clinical impact. Okay, so if we use gloves as an example of that, which I'm sure we're all familiar with, with infection prevention control, this graph shows a lot of our PPE, so that shows our gowns, our face shields, some of our respirators, our FFP3 masks, aprons, gloves, surgical masks, and it shows them there the carbon footprint that's associated with each of our PPE, our common PPE. And this includes the production, which is shown in red, the waste that's attached to it in orange, the electricity consumption through the manufacturing process in the blue, transportation, again, in a slightly darker orange, and then the production of packaging materials in the green. So you can see that gowns has got a really high carbon footprint. And I don't know about you, since I've returned from my clinical fellowship, I've now been back in the ICU department, and the amount of people I walk through theatres every day to go to and from my office and the teaching and onto the unit, and so many people wear the surgical gowns just as coats, just for them to use in the day, not even for surgical procedures. And it's one of my new bugbears, is that it's just so frustrating that I don't think people realise the carbon footprint impact they have of wearing a sterile gown just as a coat for them during that shift. Whereas we have our uniform, it's frustrating. So hopefully we can reduce things by simple interventions like that. But gloves as well is a huge one, and I think I'm going to use gloves as an example, mainly because I've been doing a lot of leading on some national gloves off campaigns, and those of you that might have already heard John Otter speak, and I know he's speaking later on today, I think gloves is a really great example to be a really good demonstration of how sustainability and IPC can really so strongly interlinked, and the benefits it can have from both, which I'll now go into a little bit more. So the carbon footprint of a glove is about 26 grams of carbon dioxide or grams or equivalent. And in each box of gloves, we have about 100 gloves in each box. So each box is about 2.6 kilograms of carbon dioxide equivalent. So to put that into context, the UK average CO2 emissions per car is about 221.4 grams per mile. So to compare, one box of gloves is about 12 miles in a car. You can see taking photos, so I'll stop there for a moment. And then if we look at 2020 for our glove use, this is the amount of gloves that we used during that time. So we've got over a billion gloves, which led to a huge amount of CO2, which is the equivalent to 216 million miles in a car. So that's just February to August in 2020. I know that was a slightly unprecedented time because that's our COVID stats, but actually we thought that post-COVID, our glove use would start dropping back down again. And initially we saw a brief drop, and we've actually now seen it climb back up again. So we're not far off this figure. So what does that mean? That would mean, if you compare that, to the moon and back is 480,000 miles. So for the amount of gloves that we used from February to August 2020, that's how many trips to the moon and back we could do from carbon emissions. So that's 450 trips to the moon and back, which is a lot. I always think that's quite breathtaking when you compare it to something to the flying to the moon and back with the amount of gloves that we use. And we find through lots of work has been done locally and regionally, and we're finding that generally, on average, 30% of glove use is inappropriate. And that's just the national average at the moment. So people are using them inappropriately. So not only do we know the consequences of that means that we've got increased waste and unnecessary use of gloves, which has a high carbon emission, but we also see the other side effects of the patient safety risks we have with increased infection rates we're seeing with inadequate hand hygiene and the inappropriate use of gloves. So what have we been doing from a national perspective? So from the Greener NHS and the Chief Nursing Office, there is hopefully soon to come, the Chief Nursing Strategy is soon to launch. I know we're in this sort of a window of our political window, which means it can't be launched. It was due to be done so, but there is now a delay. But there's 7 Ps within the new Chief Nursing Strategy, and the first P is protecting our planet. So there's a real focus on driving through changes that we can make and the roles of our clinicians within this space to start pushing the sustainability agenda. So within that team, there's been a large amount of work with sustainability and infection prevention control, which is how Val and I met. So Val was meant to be presenting with me today, because we realised that not only were we experiencing that sort of IPC says no at a very local level, but also it kept climbing up the chain, and there seemed to be a lot of ill-perceived barriers between IPC and sustainability goals. So Val and I paired together to try and create sort of more of a collaborative approach and how we could look to improving that relationship between the two teams. So we had a real look to see how can IPC and sustainability work together, where can we achieve the most benefit, and how targeted does this work need to be. So we've been doing a lot of work with a lot of external stakeholders to look how this could be at a national level, but also at a local level. So the national ambition for collaboration between the two teams was to build a IPC and sustainability collaborative. So we hold quite regular workshops to lead on the strategic plan of action, but also to provide a collaborative statement, which is in its final version, ready to be published, which sets out some of those key messages that I've kind of gone through already about the interconnectedness of sustainability and infection prevention control, but also the areas that we can maybe start to think about and target. We've also been trying to build a repository of best practice of IPC and sustainability, with the view to helping that scale and spread of best practice to aid implementation in different areas. Gloves off might be a really good example of that. Also to start including consistent language of sustainability into IPC guidance. So the national IPC team have been looking at their board assurance frameworks, for example, to try and make sure that the wording that's used within sustainability is consistent across all of our messaging, because I don't know about you, but there's a lot of different variations of the terms that we use, and it can get confusing. And the fifth thing, which I've been leading on in particular, is working with exemplar sites on adopting system whole approaches of how IPC and sustainability can work together. So I'm going to focus on a little bit more now about the exemplar sites. So the aim of this was to locally connect IPC and sustainability teams through supported collaborative practice of IPC sustainability quality improvement projects. And the ones that we trialled within Great Western Hospital as a starting point was a gloves awareness campaign in critical care, which then spread to some other wards. Reusable tourniquets, which was used trust-wide. Green theatres, including reusable theatre hats and gowns. Also, the Green E accreditation, which a huge part of that was a reduction in cannulation campaign and stopping the use of skin prep prior to routine venipuncture. There was a large waste reduction project, which was a bag to bedside, it was named, and the removal of couch roll. And also they reduced the frequency of routine sheet changes and recycling of curtains. So quite a lot of projects that all ran simultaneously at the same time. And the reason that we did this and supported Great Western to run these IPC sustainable QI projects was to see a variety of different outcomes. So firstly, the direct outcomes. We can see really quickly the quantifiable carbon and cost savings if we use gloves, their gloves awareness campaign that they ran in critical care. Not only do we see the carbon savings of the reduction of gloves, but also through cost savings and also the cannulation. There's a really good example that I'm going to show you next about some of this cost and carbon savings that we can make from simple initiatives like this. But also it was the collation of IPC and sustainability best practice to help other areas roll out these practices. So we did a gloves off campaign in critical care. ED then really liked what they did, so ED then took it, and then the maternity wards then took it over. So it was able to learn from each other quite quickly and roll out similar implementations within the same trust but across different wards. You also then get the indirect outcomes. So not only do we have the quantifiable carbon savings through the actual product reduction, but we also got reduced carbon savings through improved patient care, resulting in less requirements for care. So for example, reduction of cross-contamination or bloodstream infections would reduce a patient's stay in ICU, for example, because they don't have to continue on their course of antibiotics that they've had to be prescribed because they've got an infection through poor hand hygiene or inappropriate glove use. And then we've also got our wider system and organisational outcomes. So what we found was actually that the partnership of IPC sustainability teams were really keen to drive different either IPC best practice or sustainability best practice, but they had no mechanism of actually talking together on a regular basis within the trust. So one small part of this exemplar programme was actually just joining the dots of what's already there. And what they found when we brought the two teams together is that they had very similar ambitions and goals of trying to reduce or improve vessel health, for example, and then ED was trying to do a cannulation reduction. And actually they have very similar outcomes in the sense that not only do we reduce unnecessary cannulations, but then we're improving the satisfaction of patients through less pain and discomfort from having an unnecessary cannula, but also then the patients that had a cannula that was inserted unnecessarily, the percentage of patients that then were administered IV fluids because they had a cannula but weren't actually required was quite high as well. So it's all about the knock-on effects that we found. And I think in Imperial, so my site now, the case study from Charing Cross Hospital in the emergency department, they had noticed exactly that. There were too many sitting cannulas and they just weren't all being used. And they had a culture of a just-in-case cannula. I don't know if that's familiar to any of you that work in that kind of area, but quite often we put a cannula into a patient just in case they need it. But actually, they found that 37% of the cannulas remained unused. So 37% of those cannulas were not required. And not only is that a large emissions impact for the cannula, but it's far bigger than that of the actual venipuncture. So what did Charing Cross do? They measured the amount of patients that were cannulated and then the amount of cannulas that were unused. So their baseline data showed that 75% of all patients that came into their busy A&E site were cannulated. And as I said, 37% remained completely unused. They also did another survey where they spoke to the patients that had been cannulated, and 68% of those patients had a negative view of their cannula. They either found it painful, would rather they didn't have one in the first place. So they ran a Cut the Cannula campaign in ED and managed to reduce the overall cannulation rate by 20%. So that was their aim, but the actual outcomes were they managed to reduce cannula insertion by 34%, and approximately about 40 unnecessary cannulations a day. So not only is that a reduction in cannulas, but think of the staff time that's also associated with putting those cannulas in the first place. So the outcomes of that is that they found reduced infection rates and less inappropriate IV fluid use. And also an annual saving. So just from this first year of running the Cut the Cannula campaign, they managed to get an annual saving of £95,000, which is a staggering amount for cutting something that we don't actually need to do. We also had an annual savings of 19,000 kilograms of carbon equivalent, and also the patient satisfaction. So less pain, less discomfort, and increased independence and mobility. And it also improved workflow and the use of staff time. So you can see that one IPC and sustainability quality improvement project actually has a really large impact for the patient and the care that they provide, but also you get the triple bottom line outcomes of also not only that social value, but you get the cost and the carbon value. And I think that leads on to a very similar project that's also been running, which you might have seen already, which is the benefits of swapping IV to oral. Can we swap IV antibiotics to oral antibiotics? Because IV antibiotics can might reduce the length of stay, reduce adverse events, freeing up nursing time, reduce the use of broad spectrum antibiotics, and reduce the complications associated with infections. So that's another simple intervention that we might just keep going and going on the prescription that they have, but actually we need to start questioning, is it a good time for us to swap to IV to oral, and actually the impacts that has to our patients and our staff within the units, but also the cost and carbon benefits too. I think all of these, it really shows that there is often, I think people sometimes don't always associate with what they're doing as sustainable. Whereas I can imagine just through some of these initiatives that I've said, some of you might already be familiar with them and thinking, oh, we already try and promote our patients to go from IV to oral already. That's something we're already doing. But did you have that knowledge that sustainability, the sustainability benefits that can bring? And I think it's quite often forgotten that sustainability is a lens that we can bring to every initiative we have. And I think this Exemplar site has been a really good example of how those lenses can be brought to people that didn't know that they already had sustainability lenses on. So I think that then brings me to the Menti again. So if you haven't already completed the last 3 questions, I would really appreciate if you could scan in again and finish those final 3 questions, just so that I can get a gauge and find out what you've been doing in your practice and what sustainability then means to you. And then for any of you that are nurses and midwives in the room or have colleagues that are nurses and midwives, there is a National Nursing Midwifery Sustainability Network. If you're not already a part of, or feel free to please share this resource with any of your nursing midwifery colleagues, because IPC is a quite common feature of what things we discuss during that network. So the QR code there is the registration form, so please do either use it yourself or pass it on to colleagues that you think might find it helpful. But other than that, thank you, and yeah, if there's any questions, happy to take them.